Welcome to our discussion of the anatomy of the brachial plexus above the clavicle. The interscalene space is defined by the anterior and middle scalene muscles and their attachments. In this figure on the left of the screen, the scalene muscles are absent in order to demonstrate the anterior and posterior tubercles located on the transverse processes of the cervical vertebra. In the diagram on the right, you see how the anterior scalene muscle attaches proximally to the anterior tubercles and the middle scalene attaches to the posterior tubercles. Note that the distal attachments for both muscles are on the first rib. We commonly describe a supraclavicular block as being different than a traditional interscalene block. Technically, however, any plexus block above the clavicle is within this space bordered by the anterior and middle scalene muscles and could be considered an interscalene block. Finally, we see that the subclavian artery passes over the first rib posterior to the scalene muscle with elements of the brachial plexus accompanying it. By contrast, the subclavian vein lies anterior to the scalene muscle as it passes superior to the first rib. Thus, its position relative to the artery and brachial plexus may vary between the first rib and the axilla. This drawing shows the position of the phrenic nerve relative to the scalene muscles and the brachial plexus. The phrenic nerve exits from between the scalene muscles at approximately the level of C6 and passes anteriorly and inferiorly across the surface of the anterior scalene muscle. The position of the phrenic nerve in the interscalene groove at the level of C6 makes it vulnerable to injury during a traditional approach to the brachial plexus when needle insertion is performed in this groove between the anterior and middle scalene muscles. Next, we will look at some fresh cadaver dissections of the interscalene region. In this fresh cadaver dissection of the right neck, the mandible and clavicle have been labeled to orient the viewer. The sternocleidomastoid muscle has been marked with a suture tie, and the middle scalene, anterior scalene, and brachial plexus as well as the omohyoid muscle have all been labeled. The phrenic nerve is clearly visible, held with forceps, and marked by the white arrow as it emerges from the interscalene groove and passes inferiorly across the surface of the anterior scalene muscle. In this image of the left neck, the sternocleidomastoid, anterior scalene, brachial plexus, and middle scalene are labeled. When the video clip is played, the phrenic nerve will be visible as it passes across the surface of the anterior scalene muscle and into the interscalene groove. The phrenic nerve appears as a small, round, hypoechoic structure on the superficial surface of the anterior scalene muscle. The path of the phrenic nerve is marked by 3 white arrows. In this video loop, you will see superior and inferior movement of the transducer on the inset screen and the corresponding ultrasound images. As the transducer is moved superiorly, the position of the phrenic nerve can be traced from anterior to posterior across the surface of the scalene muscle. The phrenic nerve is not readily visible with ultrasound in all patients, however. Next, we will review some arteries in the interscalene region using a fresh cadaver dissection. In this fresh cadaver dissection, the sternocleidomastoid and other surrounding tissues have been removed to display the thyrocervical trunk of the subclavian artery. Note the positions of the anterior scalene, brachial plexus, and middle scalene relative to the subclavian artery and the thyrocervical trunk. Not infrequently, arterial branches from the thyrocervical trunk will be visible in the path of the injecting needle. There is some variability in how these vessels are named. Branches from the thyrocervical trunk include the transverse cervical, dorsal scapular, the ascending cervical arteries. Suffice it to say that the most common practical application of this anatomy is to look for and avoid these branches of the thyrocervical trunk. Next, we will review some of the branches of the thyrocervical trunk that are commonly visualized when performing ultrasound in the interscalene region. This ultrasound image shows a prominent branch seen in long axis along the superficial surface of the cervical fascia, marked with white arrows. In this image, there is a branch of the thyrocervical trunk, the transverse cervical artery, which actually is traversing the brachial plexus in the interscalene space. Next, we will talk about the dorsal scapular and long thoracic nerves. The dorsal scapular and long thoracic nerves are pure motor nerves that originate from C5 and C5-6 respectively. The dorsal scapular nerve innervates the rhomboids and levator scapula, while the long thoracic nerve innervates the serratus anterior. These are the most superficial branches of the brachial plexus and can be seen within the body of the middle scalene in most patients. Their positions relative to the scalene muscle make them vulnerable to injury during an approach to the brachial plexus through the middle scalene muscle. This is a graphic representation of the appearance of the dorsal scapular and long thoracic nerves in relation to other structures in the interscalene region. The dorsal scapular and long thoracic nerves are almost always visible when performing ultrasound-guided interscalene block using an approach through the middle scalene muscle. This fresh cadaver dissection of the right neck shows the anterior scalene, brachial plexus, middle scalene, as well as the phrenic nerve crossing the surface of the anterior scalene muscle. Note that the long thoracic nerve and dorsal scapular nerves have passed into the substance of the middle scalene muscle. These are both pure motor nerves. The long thoracic nerve provides motor for the serratus anterior, and the dorsal scapular provides motor for the rhomboids and levator scapula. In this image of the right neck, we see the anterior scalene, middle scalene, brachial plexus. The dorsal scapular and long thoracic nerves are visible within the body of the middle scalene muscle and are marked in this image with white arrows. With the transition to ultrasound for regional anesthesia, approaches through the middle scalene have become very popular. The positions of the long thoracic and dorsal scapular nerves within the substance of the middle scalene muscle are important to recognize in order to avoid injuring these nerves. With the introduction of ultrasound for regional anesthesia, it is possible to perform nerve blocks without immediate proximity of the needle tip to the nerve. This concept is appealing since direct needle trauma is one of the recognized causes of nerve injury. The interscalene brachial plexus is a good example of how fascial planes can be used to facilitate nerve block without immediate proximity of the injecting needle to the nerve. Next, we will examine how fascial planes surrounding the brachial plexus affect the distribution of local anesthetic. In this fresh cadaver dissection of the neck, the middle scalene, brachial plexus, and anterior scalene are all visible. A close examination of the brachial plexus reveals that the individual roots and trunks are not visible. Rather, the elements of the brachial plexus are surrounded by connective tissue, which is being held by forceps in this picture. In this image, the clamp and the white arrow show the tissue plane where local anesthetic can be injected for successful block. This is a close-up of the same dissection displayed in the previous slide. However, in this image, the connective tissue surrounding the brachial plexus has been incised, revealing elements of the brachial plexus within. The white arrows highlight the incised edges of the connective tissue, and the anterior and middle scalene are also labeled in this image. This is a graphic display of two possible approaches to the interscalene block of the brachial plexus. The black oval represents the connective tissue layer surrounding the brachial plexus. The green layer represents the deep cervical fascia. The first pattern results from injection between the anterior border of the middle scalene and the connective tissue surrounding the brachial plexus. The second pattern shows the distribution when injection is performed deep to the connective tissue surrounding the plexus. Since 2006, we have used the technique demonstrated in this image. A study published in 2009 confirmed the effectiveness of injection outside the connective tissue surrounding the plexus in 200 consecutive patients. To illustrate the distribution of local anesthetic after injection in the tissue plane between the middle scalene muscle and the brachial plexus, we perform percutaneous dye injection using ultrasound guidance in a fresh cadaver. The drawing on the lower right corner of the screen shows the injection technique. After injection, the neck was carefully dissected down to the scalene muscles. The deep fascia overlying and between the scalene muscles was left intact. This image demonstrates that precise injection between the anterior border of the middle scalene and brachial plexus is contained within the space bordered by the scalenes and the investing fascia. In this image, the fascia between the anterior scalene and middle scalene has been incised, showing the interscalene space. Note that despite injecting only in the fascial plane between the middle scalene and the connective tissue surrounding the brachial plexus, dye extends throughout the interscalene space between the brachial plexus and the anterior scalene as well. Now we would like to show you a systematic approach to imaging the brachial plexus. This is an example of the technique used to image the interscalene region. This particular image is of the left neck. The procedure starts by positioning the transducer parallel to the clavicle and directing the ultrasound beam into the root of the neck. Using firm pressure and holding the transducer motionless, the pulsations of the subclavian artery are visible. The brachial plexus can be seen in a position that is posterior and superficial to the subclavian artery. The transducer is then moved superiorly while continuing to exert firm pressure on the transducer and maintaining the plexus in the center of the screen. The anterior scalene, middle scalene, and brachial plexus are readily visualized. In this particular example, if you watch this clip again, you will notice the phrenic nerve, a small hypoechoic sphere that passes over the surface of the anterior scalene muscle and into the interscalene groove. This is an example of the same technique on the right side of the neck. Again, the procedure starts by positioning the transducer parallel to the clavicle and directing the ultrasound beam into the root of the neck. Using firm pressure and holding the transducer motionless, the pulsations of the subclavian artery are visible, and the brachial plexus can be seen posterior and superficial to the subclavian artery. The transducer is then moved superiorly while exerting firm pressure, which will highlight the anterior scalene, middle scalene, and brachial plexus. Also in this image, note the position of the dorsal scapular and long thoracic nerves in the middle scalene muscle. This is one more example of ultrasound imaging of the brachial plexus from the level of the clavicle to the level of the cervical vertebra. The procedure again starts by positioning the transducer parallel to the clavicle and directing the ultrasound beam into the root of the neck. Again, using firm pressure, holding the transducer motionless, the pulsations of the subclavian artery are visible. The brachial plexus can be seen posterior and superficial to the subclavian artery. The transducer is then moved superiorly while exerting firm pressure, which will highlight the anterior scalene, middle scalene, and brachial plexus. This is a recording of a right interscalene catheter placement. The image on the left of the screen shows the transducer and needle position simultaneously with the ultrasound view. This initial image shows the positions of the middle scalene, anterior scalene, brachial plexus. An 18-gauge standard bevel needle is advanced in plane with the transducer. Note that the needle advance is accompanied by frequent hydrodissection. The hydrodissection is done both as a secondary means of confirming position of the needle tip as well as a means of identifying the tissue plane between the anterior border of the middle scalene and the connective tissue surrounding the plexus. Note the distance between the needle tip and the brachial plexus when the catheter is actually advanced. Also, if you review this clip, you will note the pulsations of an arterial branch of the thyrocervical trunk in a plane immediately superficial to the deep cervical fascia. In this recording, a right interscalene catheter has been placed. The brachial plexus, first rib, subclavian artery, middle scalene, and anterior scalene have all been labeled. The catheter is then injected with 1 cc of agitated saline to confirm the position of the fenestrated catheter tip. The agitated contrast is visible along the inferior border of the plexus, and the plexus is outlined by the yellow border. This test is useful if there is a question about whether the catheter has been dislodged. We should note, however, that while interscalene catheters are usually visible with contrast injections, when imaging femoral and sciatic catheters, the injection is not always visible since the catheter tip often is in the correct tissue plane proximal or distal to the ultrasound beam. In this right interscalene approach for catheter placement, note the positions of the brachial plexus and the dorsal scapular long thoracic nerves. In light of this finding, we have altered our needle approach in order to avoid trauma to the dorsal scapular and long thoracic nerves. The positions of the anterior scalene, middle scalene, brachial plexus, and dorsal scapular long thoracic nerves and the thin-walled needle are shown. The initial approach is horizontal, and then approach is made superficial to the middle scalene, and the angle is dropped steeply in the space between the dorsal scapular and brachial plexus. After hydrodissection, as the catheter is advanced, note the positions of the brachial plexus needle and dorsal scapular long thoracic nerves. Here is one more reminder of how to locate the interscalene brachial plexus. The transducer, again, is placed parallel to the clavicle. The beam is directed into the root of the neck. The transducer is held firmly against the skin while looking for the pulsations of the subclavian artery. The brachial plexus will be visible and posterior to the subclavian artery. The transducers then move superiorly while maintaining the brachial plexus in the center of the image. Now we have found the brachial plexus and we're about to advance a catheter. Notice the distance that is maintained throughout the procedure between the needle tip and the brachial plexus. Similarly, note the distance between the needle tip and the dorsal scapular and long thoracic nerves. Thank you.